So by way of introductions, our second presenter today is student Dr. Camille DeMarcus, who's in her second year of med school on the Kansas City campus of KCU. Thank you so much for volunteering, student Dr. DeMarcus. We appreciate you. She graduated from University of Arizona. She's a rattlesnake with 22 with honors in physiology and has worked on several research projects over the past few years, including such topics as breast cancer, anesthesia, EEGs, and Alzheimer's disease. She's not focusing on academic pursuits. Student Dr. DeMarcus can be found trying to keep 2 Shetland sheepdogs under control or driving alone the back roads. Today, she'll be presenting the results of her research project she completed for her undergraduate honors thesis, and the title of her talk is Consequences of Social Isolation on Elders with Alzheimer's Disease and Care Facilities, a Systematic Review. Student Dr. DeMarcus, the stage is yours.
Thank you very much, Dr. Staudinger. First of all, thank you very much for having me. And also, you see the slideshow or the presenter show?
You're good. Slideshow.
Okay, perfect. Thank you. All right. So like Dr. Staudinger said, my project is called Consequences of Social Isolation on Elders with Alzheimer's Disease in Care Facilities. And this is a systematic review. I'm working in conjunction with Dr. Ying-Hui Cho, who's from the University of Arizona, as well as Carly Shellman, who is also an OMS2 at A.T. Still University in Arizona. So without further ado, okay, so what is this project about? Well, it basically revolves around this quote that says we must prevent social distancing from becoming social isolation. It revolves around this quote, as well as the fact that over 6 million people in the United States have Alzheimer's disease, and this number is only expected to increase from now. And those 6 million people make up about 50% of nursing home residents. And this is really important because in nursing homes, just like in preschools, elementary schools, or even in cruise ships, facilities like that, contagious diseases can suddenly outbreak, and there are isolation protocols within those places. And contagious diseases can include C. diff, shingles, flu, or more recently, like we're all aware of, COVID-19. And so basically what we're trying to do is we're trying to look at how isolation in those facilities can affect the mental health of individuals with Alzheimer's disease. And we know that the disease state of Alzheimer's, with that disease, it's difficult to obtain reliable information from these patients. But we have COVID-19. Although it's not an exact match or exactly comparable, we can use it as an analog for what an Alzheimer's patient might be going through during isolation. So first of all, a little bit more background. What is Alzheimer's disease? Well, it's a progressive neurodegenerative disease that falls under the umbrella of dementia. And dementia is any loss of memory, and that can be caused by diseases such as Alzheimer's disease or even things like trauma. Alzheimer's disease has a couple of biological markers. In the simplest form, they're tau tangles and amyloid plaques. Both of these accumulate in the brain and lead to decreased synaptic efficiency and decreased communication. Previously, the only diagnosis method for Alzheimer's disease was on autopsy, but recently they've started implementing new tests such as cerebral spinal fluid tests, imaging biomarkers, and blood tests. And although these are available, they're very costly and very rare to come by. And worst of all is that there's no cure for Alzheimer's disease. There are methods and medications that are currently used to slow the progression, but none of these work by changing the underlying cause or fixing the underlying cause of Alzheimer's disease. So a lot of the times, many patients and their families start looking for different care methods. So there's a bunch of choices that come with choices in long-term care. First, you can choose family. This is great, but it can be extremely taxing on the family, as you can imagine, and somebody has to have a lot of time to take care of this patient, especially in advanced stages. You can also hire at-home care services. These are third-party vendors, and their services can range all the way from just companionship, hanging out with the patient during the day so they're not lonely, all the way to having a registered nurse come and do some skilled care with these patients. And finally, care facilities is what we're going to be focusing on most today. So care facilities come in three main flavors. First is assisted living facilities. These offer minimal help with activities of daily living, and by that I mean getting dressed in the morning, feeding yourself, cooking, cleaning your areas, etc. In these facilities, residents can be free to come and go as they please, so you can think of them as like retirement homes. In nursing homes, these offer full support of the activities of daily living and are more of a clinical setting. And finally, long-term memory care facilities, like nursing homes, provide full support and clinical support, but they are also highly secured lockdown facilities in that they have, for example, several doors to go through with PIN codes that change every month or every week so that residents cannot get out and start wandering. So for this project, we were specifically interested in nursing homes and long-term care facilities for three reasons. Number one, they're more secluded by nature. Number two, they have a higher rate of Alzheimer's disease patients in them. And number three, they have those very specific contagious disease outbreak protocols within them. So what is social isolation? I've been talking about it so much. But basically, the main getaway from what is social isolation is that it's not loneliness. A lot of the articles that we found addressed loneliness during these time periods, but it's not the same. Loneliness is more of an emotion, and it can be either quantitatively or qualitatively measured. While on the other hand, social isolation is more exact. It's little face-to-face contact, little physical contact, little possibilities of physical activities, as well as the uncertainty about the duration of the isolation. And I feel like we all went through this to some extent during COVID-19, which is why it was first thought of for me as like a good analog. So this project is looking to investigate the effects of cognitive isolation that's inherent to the Alzheimer's disease. As they progress in the disease, they're unable to vocalize their wants and needs, so that could lead to some sort of cognitive isolation, as well as physical isolation that is possible due to these contagious disease outbreaks. And what is COVID-19? We all went through it. We're all very familiar, so I'm going to breeze through this slide. So COVID-19 is caused by SARS-CoV-2. There's a bunch of screening tests. I'm sure we all did a bunch of those as well. There's a PCR test, some antigen tests, antibody tests, etc. And everyone is susceptible, especially if you're over the age of 50, have underlying health issues, or if you have recently been pregnant as well. And the CDC made a lot of recommendations, as we're all well aware of, that 6-foot rule, avoiding those large groups, and wearing face masks for a long time. But the most important and most relevant to this project was that the CDC recommended that countries implement mandatory quarantine periods during the pandemic. Now to the good stuff. So my systematic review was, like Dr. Staudinger said, originally part of my undergraduate honors thesis, and it was a literature review. And now I'm partnering with Carly Shulman from AT Still to revamp it. And with this, instead of looking at just PubMed like I did for my original project, we're also including Embase and Scopus, and we're also adding more criteria for inclusion and exclusion, such as only in the United States, so as to mitigate cultural differences in isolation, and articles that aren't looking at alcohol drug abuse, so that to mitigate the mental health effects that may come about because of that. And articles that aren't focusing on essential workers because, as we all know, they went through a lot being an essential worker and being in that environment, and so they might have different health outcomes because of isolation as well. So for the purpose of this presentation, I'll be presenting the findings that came from the honors thesis, since the revamp is not completely done yet. So for my preliminary project, we had 3 searches. The first search was for younger adults with COVID-19 isolation. The second, older adults with COVID-19 isolation in care facilities. And the third was individuals with Alzheimer's under COVID-19 isolation in care facilities. As you can see, these searches got more and more specific for the population that they were looking at. And similarly, you'll see later that the amount of articles that pertain to each search got smaller as we went. And for this preliminary project, I also included suggestions that each of the articles made in order to mitigate the effects of the isolation as well. But unfortunately, the suggestion section, I don't think is going to make it to the revamp. And then finally, the inclusion and exclusion criteria for the first project was that it must include COVID-19 isolation. Search number 1 with the younger adults must be a survey that was administered during lockdown periods. And search number 1 and 2 had age cutoffs. For search 1, it was 18 to 65, and search 2 was 65 and above. And I used the average age as well. And then also, there couldn't be any disabilities that could further skew the results of the mental health effects. And that's, for example, a cancer diagnosis or addictions and stuff like that. For the preliminary project, we had 19 articles in search 1, 5 in search 2, and only 2 articles in search 3. And a lot of the articles focused on physiological effects such as heart rate or breathing rate or increased mortality. I tried to stray away from those and focus more on the psychological effects rather than the physiological effects, since that's where it's mainly lacking in the literature. So the results. For search number 1, we found that there were increased rates of depression, distress, anxiety, sleep issues, suicidal ideation, and loneliness, among other results. But these are the most common. And those are all the articles that mention those findings. There's a couple of main points that we drew from search 1, since it was our largest group. First of all, since these are people in the ages from 18 to 65, we can assume that accurate data was collected from these individuals about their perceptions and their mental health status during isolation. Again, there's significant increases in these characteristics that I mentioned earlier. And a special interest is that these individuals, 18 to 65, most of the articles were of college-age students who were in school at the time. There was found to be cognitive decline over the period of isolation. And these are individuals who are, in theory, at the top of their cognitive game and attending school and doing great, and they still found that decline. Also, interestingly, was that 95% of the lockdown patients knew the purpose of the lockdown, something that may not be true for patients with Alzheimer's disease, especially in the later stages. And a lot of the papers focused on comparing confounding variables or comparing other characteristics such as gender, age, minority, novel prescriptions, and previous diagnosis of mental health issues. A lot tried to compare whether or not males or females had worse outcomes during the isolation, or if older adults or younger adults had worse outcomes. Some suggestions made by Search 1 papers were to implement education programs so that people in the isolation periods could know why they're there, know what to expect, or at least be able to talk about what they're going to be expecting. And that goes into the second and fourth point, the availability of mental health treatment and resources during the isolation periods. Having those resources available and ready to go is of the utmost important, and also making it tailored to all demographics, because like I said, different demographics could be experiencing isolation in different ways. And then finally, there's a lot of evidence that continuing in a routine can minimize the negative mental health effects of isolation. Search number 2. Just a reminder, this was individuals over the age of 65 years old who are in care facilities. So there's a wide variety of changes in these individuals, including mental and physical deconditioning. But this age group in particular showed remarkable adaptability and resilience during COVID-19 lockdowns, since initially their levels of loneliness and social isolation increased, but then evened out over a certain period of time. And interestingly, the characteristics of the care facilities themselves was very indicative of the mental health outcomes. Some of the notable characteristics include higher numbers of beds and patients, high traffic nature of nursing homes, and a for-profit status of the facility. This search also addressed the use of technology quite a bit, which was interesting. However, contradicting themes arose. Some articles highlighted the importance of technology so that way they could make up for the lack of in-person interactions, but others went as far as to say that technology doesn't have the capacity to replace human interaction for any amount of time, period. But so, either way, some of the important considerations for using technology in these time periods is the proficiency of the group in particular that you're talking about, and also the accessibility to the technology. There are also some suggestions as to the care facilities. We need to address understaffing, which is difficult during a pandemic such as COVID-19, but more doable during smaller breakouts such as C. diff, shingles, etc. Assigning more carers to a patient who is under lockdown would be beneficial. Also, training staff to be more able to reorient patients, to reassure them, and to provide cognitive stimulation. That kind of goes with number 1, too. And then addressing those characteristics of the facility that I mentioned not too long ago. And now the role of the family was also brought up here too. The family plays a huge role in the patient's care, representing the patient, and keeping the patient in as positive spirits as possible. However, it's very overlooked in literature. Only a handful of articles even mention family. In the final search, there was a lot of negative influences of isolation on the mental health of these individuals. And to remind you, these are individuals over the age of 65, have Alzheimer's, and are in a care facility during isolation. So a couple of suggestions that were made here. Number 1, be cognizant that the unfamiliar PPE that you may be wearing may lead to more negative effects on these patients. They may already have a difficult time recognizing who's taking care of them, or they may feel uncomfortable where they are because it's a new setting. And so further not being able to recognize people might be disturbing to some. Also, encouraging the routines, like I mentioned earlier. Stimulating movement, going for a walk, even if it's around your room a couple of times a day, is important. And most importantly, I think, is collaboration with mental health professionals. Individuals with Alzheimer's disease usually don't follow up with mental health professionals after their diagnosis because people think that they're unable to vocalize what they want. They're not reliable sources of information, or it's just because of their disease progression. But these people are probably the most in need of somebody to talk to and somebody to sympathize with them because of all the changes that are happening in their life. Social aspects of care, they encourage families and friends to drop off letters, drawings, other packages, even check in with them, whether it's through a window. I know a lot of nursing homes did that during COVID-19, or even across the room. And then continuing in small group activities. If somebody else in the nursing home is also infected, maybe let's hang out with them. At least it's somebody else to be with and to interact with. And in certain circumstances, of course, with caution, offering a family member to move in with the resident is an interesting point of view as well. So the discussion, we found that in searches 1 and 2, it is likely that individuals with Alzheimer's disease face mental health challenges when forced into isolation due to contagious disease outbreaks, especially in care facilities. And it might be even more profound than we think due to their already fragile state of mind. And so more effort should be made to understand this area of long-term Alzheimer's disease care. Now, we understand that it's difficult to obtain detailed feedback from individuals who have Alzheimer's disease, especially in later stages, but more of an effort needs to be made because per Johns Hopkins Medicine, patients with Alzheimer's disease are aware of events surrounding them well into disease progression. They may not just be able to verbalize it. So we come back to our quote, we must prevent social distancing from becoming social isolation. Thank you.
Student Dr. DeMarcus, thank you. I want to make a a couple of remarks, but before I do, I want to point out that in the chat, I dropped a series of links, all of which you can click on to get the YouTube playlist of all of these talks over the last 4 years, as well as other links that inform this seminar session. So let me get to you, Dr. DeMarcus, a couple of comments. Like Dr. Peters, student Dr. DeMarcus, you're continuing your passion, and it's clearly a passion of yours, from your undergrad now into medical school, and continuing your writing interests in the same area by producing yet another review on the same topic. So I appreciate that about you. And I'll also say the mechanics of your presentation were outstanding. So I'll stop there. Dr. Johnston, go ahead.
Dr. DeMarcus, our student Dr. DeMarcus, again, want to compliment you on your presentation. Very well done. And slides were so easy to read and understand, and you have good command of that. I have a couple simple questions for you. When you referred to as technology and was implemented to avoid loneliness, what technology are you talking about?
Yeah, so those ranged actually from Zoom interactions, so a lot of like FaceTime or Zoom. And they also included, I think a couple of them looked at social media as an outlet as well. And many addressed the fact that that actually led to more of an idea of fear of missing out, or more feelings of loneliness and social isolation, since they could see people but not be with them.
Okay, that's good. Well, I think you, I mean, on our generation, your generation, and any of us that had COVID or we were restricted to isolation and so forth, particularly those that are in the developmental stage of youth and transitioning into young adults, a lot of folks that were isolated for various reasons, infection being one, did lose some ability for socialization. Not just in a nursing home setting, but in the real world. You were kind of captive to that dorm or that room or this, et cetera. So you couldn't get out. So we lost some of our ability to communicate. This is part of, I guess, the doggone sequences or sequelae from the virus that put us all in that same boat. This is a more captive, different type of audience relevant to the world of Alzheimer's. Again, very appreciative of your presentation. And was there anything that you were surprised with when you're studied all this and are now making this presentation?
Yeah, I think actually the lack of family involvement, or the family looking at how they affect it, that was one of the main surprises for me. And then also the technology. I thought that the technology would have helped these individuals, but like I said, it was completely opposite. And it, as a matter of fact, made most people feel worse about the position that they were in.
Some of that technology may just have blown them away and they weren't able to get up to speed to use it. Thank you very much. I appreciate it.
Sure, thank you.
And one thing that stuck out to me was the importance of routine that you mentioned. From my own personal experience with COVID, I was able to keep my routine because I was declared essential and just kept coming to work. And that gave me so much comfort while everybody else seemed to be locked down. Got to a point where I started feeling a little guilty because I'm not locked down like everybody else. And anyway, that was an interesting part of your talk. Dr. Wolf, go ahead.
Yeah, I maybe following up a little bit on that. I too enjoyed your presentation. Among the things that was interesting to me, and I guess I'm going to define introvert versus extrovert first. So I heard a definition once of introvert versus extrovert that I liked. And that was that the introvert was the person who got home at the end of the day and plopped down on the couch and played guitar or did something because they'd spent the whole day being at a level above their comfort zone, whereas the extrovert got home and the first thing they did was run around and get outside because they had been suppressed all day. And it seemed to me that being the introvert that I was, I could have lived in COVID forever because it didn't bother me in the least. Whereas I had advisees that were climbing the walls because they just couldn't make a go of things. And I was curious to what extent that played into like your search 1 results. And then with respect to search 2, it seemed to me that when you're elderly, you've had to come to grips with your physical limitations. So running outside and doing stuff is going to make you potentially have to cope with the realities of your life.
Yeah, that's a great point. As far as search 1 went, there really wasn't a lot of mention of whether or not the effects would be different from introverts versus extroverts or based on personality. I think I recall maybe one article that dealt with personality types, but we excluded it because it didn't fit into our inclusion criteria. But that is a really good point, and I think that's one of the limits of our study is personality in general. I mentioned in search number 2, the elders in nursing homes, that a lot of them showed resilience in overcoming this obstacle. But then a lot of them, a good chunk, I think about 20%, didn't show that resilience. And as a matter of fact, plummeted even lower. And so that may very well be due to personality and preferences as well.
The other thing I was curious about, you mentioned family. So when you have me in NMSP, I'll be talking a little bit about some of my experiences, I guess. But I worked in a nursing home for a year, and I was struck by the fact that these people sat around essentially waiting to die. I took care of severely handicapped people for the most part, but there were no conversations. And it seems to me, I saw a thing with Sanjay Gupta recently where he was talking about the best way to minimize cognitive decline was by walking and talking. And so that is giving you exercise, and that is engaging your brain. And then the other thing that supposedly helps is blood pressure control. And so to the extent that you can do those things, it made complete sense to me that, I mean, if there's nobody talking to them, I mean, my pet peeve working in a nursing home was when somebody would walk in and go, "How are we doing today?" I mean, I always walked in and called people by their name and at least tried to engage them in a little bit of conversation. And so along those lines, you know, I wish you the best of luck with what you're trying to do here, because I think that is where there's some real need.
Great. Thank you very much for sharing that. And I agree with you. I had some personal experience in nursing homes as well. And we definitely maybe need to start with training and more empathetic care of these individuals too. Yes.
Student Dr. DeMarcus, what year in medical school are you?
2nd year.
Okay, very, very well done.
Impressive.
Thank you.
Listen, everybody, we're out of time. In the interest of time, I'd like to once again thank Student Dr. DeMarcus and Peters. Both of you were amazing. And before I let you all go, please look in the chat. There's a draft schedule. If you double click on the PDF document I put there, you'll see a list of names. And I'll send this out from time to time through MKRC Canvas and hopefully get announcements on. Thank you, Dr. J, for allowing us to capitalize on Gwen's expertise to get these announcements out on my KCU. Appreciate that.
Yeah, we need to, all of us need to talk it up.
Agreed. But I tell you, the students are aware of it. I mean, if you look at that list, many of them are doubled up. The numbers of students that are coming to this room is amazing. So Student Dr. Peters and DeMarcus, please do talk it up. And there's some slots left. You can see where there's one individual giving a talk on this day or that day. We'd like to double up and accommodate as many students as possible. But there's some good stuff heading your way. And this will be updated. And every week I'll update it and drop it in the chat kind of thing. Thanks, Dr. J. Take care. Appreciate Appreciate you guys.
Thank you very much.
Have a
Thank you.
great rest of your day, and look, I'll communicate with the recording links as soon as possible.
Okay, thank you.
Take care, you guys.